This is the 12th week, so we're going to tackle chapter 8 this week. It's kind of a big one, so bear with me. We're going to talk about drug use and prevention from cradle to grave. So we'll try to get through this thing. A fetus is exposed to heroin through the umbilical cord after an addicted mother shoots up. This happened to in my family, of course. I've told you about great my great niece and my great great nephew. Yeah, great great nephew. He was addicted to heroin when he was born. 14-year-old is offered MDMA at a party to get rolling. A college student troubled by bulimia makes herself throw up 5 times a week. A young mother with 3 children hides in her room to smoke crack. 28-year-old IV methamphetamine user injects his girlfriend with HIV when having sex after using a contaminated needle. In one office, one worker is taking Klonopin to deal with the anxiety, while another takes Prozac to combat depression. A mother with grown children battles boredom and the empty nest syndrome by compulsively playing poker machines at a casino. 50-year-old salesman on the road smokes and drinks to cope with loneliness. 74-year-old with arthritis borrows hydrocodone from a neighbor to relieve the pain. Prevention and treatment throughout life. Encourage pregnant mothers to attend prenatal care programs to teach them how drugs affect their fetuses. Greater public scrutiny of parties limiting the use of club drugs. Has to do with the MDMA. Offering counseling on eating disorders at high schools and colleges. Using outreach workers to encourage drug users to practice safe sex and use clean needles to prevent the transmission of HIV and hepatitis C while attempting to bring them into treatment. Doing an intervention to get a heavy drinking sales representative into an employee assistance program, an EAP, employee assistance program. Holding seminars to enlighten senior citizens about drug cross-reactions. Each society has to decide how they want to attempt to prevent self-destructive drug use. Are they trying to prevent any use of psychoactive substances? Are they trying to ban just illicit drug use? Are they trying to limit the damage caused by use, abuse, and addiction? What are they trying to do? Do they want all psychoactive substances taken away? This is an argument that was very frequently presented to me when I was arguing about whether they should legalize marijuana. Well, alcohol's worse. Yes, alcohol's worse than marijuana, but alcohol's already legal, and the question is, should we add another toxic substance to the legal substances that people are allowed to use? This is one of the arguments that we talk about. The use in most other countries use the United States. I'm sorry, the United States and most other countries use a 3-tier approach to fight the destructive effects of psychoactive substances. Primary prevention program to teach the skills to help the individual resist drug use. The secondary prevention is stopping the behavior wherever and whenever it starts. And tertiary prevention, putting people through the treatment and restoring them to health. So the best thing to do is to stop them initially. But if that doesn't work and they do start, then you need to stop it wherever and whenever you can, wherever you see it started. And then, of course, if they use it and you haven't stopped it, then you need to put people in a treatment and program and restore them to good health. Governments work on prevention by reducing the supply of drugs through the interdiction of drug supply, legislating against its use, and legal penalties for possession, use, and distribution. This is what we've done in the United States. We've tried to stop the drugs from coming into the United States. We've legislated against its use. It's not legal in the United States to use heroin or crystal meth. And we have put people in jail trying to slow down the use of the drugs. Reducing the demand by treatment of drug dependency and prevention through education, emotional development, moral growth, and individual and community activities. Reduce the harm that can be done to the community by promoting temperance, instituting needle exchange programs, supporting drug substitution programs, lessen the effects of alcohol, for example, by using a designated driver, and decriminalizing drug use. These are the attempts to reduce the harm to the community. Worldwide, the most widely used and successful programs have been supply reduction and temperance methods. Historically, in the United States, drinking and smuggling of spirits became part of the American fabric. It was easier for farmers on the frontier to ship their corn produce in the form of corn liquor than as grain. Grain was just too heavy and bulky, but it was much easier to take the grain and reduce it in distill it into the form of corn liquor, and it was much easier to transport. And they made as much money off of it as they would if they had shipped the corn whole. However, with the influx of evangelical influences, there was a Methodist and a Baptist revivalist movement in the United States in the early 1700s. First there was a Methodist movement, and then later on in the 18th century there was a Baptist movement in the United States. Temperance became more acceptable as an alternative to heavy drinking and drunkenness. Such behavior came to be seen as destructive, sinful, and immoral, especially by the Methodist and Baptist churches. The Methodist and Baptist churches, even to this day, do not support drinking. They also don't support dancing, which they feel, dancing and music, which they feel supports drug use. An effort was made to get drinkers to switch from hard spirits to weaker beer, wine, and hard cider. And this is one of the things that we talked about earlier. The fact that in the United States, there were a lot of people drinking some really heavy liquor, the corn whiskey, for example. So what they tried to get them to do was drink things that weren't nearly as toxic, like beer, wine, or cider, hard cider. Um, It worked or it didn't work. Dealing with the problem of alcohol consumption has been a continuing problem in the United States, fluctuating between moderation and forced abstinence. And of course, the forced abstinence was prohibition during the from 1920 until 1933. As a country, use and the responsive movements have waxed and waned in 70-year cycles since the beginning of our history. In 1780, Dr. Benjamin Rush tried to legislate control over distilled spirits. In 1850, the temperance movement supported replacing distilled spirits with more benign drinks. In 1920, prohibition of alcohol. In 1990, legal drinking age was raised to 21 nationwide. Before 1990, the legal drinking age was in some states was 18 years old. Did the 18th Amendment work? Alcoholic psychosis admissions to state hospitals in New York and Massachusetts were cut nearly in half. Deaths due to cirrhosis of the liver were cut in half during Prohibition. There was less crime in general. There was less domestic violence. Even after Prohibition stopped, drinking levels remained low and didn't return to pre-Prohibition levels until the 1950s. So it worked for 20 years. Yeah, it worked for 20 years. Medical problems decreased from unregulated manufacturing of alcohol, but the level never approached the medical problems that the nation experienced from alcohol. Alcohol has been very destructive to the people in the United States. But smuggling alcohol was one of the ways that we financed the American Revolution. Some argue that prohibition brought organized crime to the United States, but in reality, organized crime has been a part of the American underworld fabric since long before the 1920s. Unfortunately, one problem with prohibition was that because banning alcohol was touted as a cure for all of society's ills, treatment for alcohol addiction was cut. Some people claim that prohibition was repealed because of the universal condemnation of the ban, but the real reason for its repeal was due to the need for tax revenues from its manufacture and use during the Great Depression. Pressure from wets and fatigue dealing with the continued argument did not hurt either. So the reality is that prohibition actually worked. It did work. But the problem was that it cut funding for the treatment of people suffering from addiction, um, and we lost all that tax revenue. One of the arguments for legalizing marijuana is that we'll make so much money. The question is, we can go to the states that have legalized marijuana and look at their tax revenues and find out, is Colorado wealthy now? Is Washington State wealthy? They were two of the first states to legalize marijuana. Do they have they cut taxes for everyone? California's legalized marijuana. Has the revenue in California gone up? What's going on here? In 1962, before the civil rights movement it hit its stride, and before the Vietnam War, only 2% of the American public used illicit drugs. Now, you got to remember that I was born in 1949. So in 1962, I was 13 years old. And I can tell you that drugs, whether it's marijuana or whether it's heroin or crystal meth didn't even exist at this point. But I didn't know anybody that used anything. The hardest things that I ever saw were potentially bottles of whiskey and beer. That was it. I mean, there was nobody using illegal drugs in the United States. Of course, I'm from a rural area in Indiana, so possibly I didn't see any of this. If I had lived in New York City or Philadelphia or Los Angeles, I probably would have seen something. But because I was living in the rural portion of Indiana, I didn't see any of this. However, after the 1960s and 1970s and everything changed a little bit, then you did see marijuana being used in rural Indiana and rural Illinois. You saw it in Ohio and whatnot. However, with the aforementioned social movements and an era of social disobedience streaking through the youth of the 60s and 70s, 31% of the population was using illicit drugs. 31% of the population. It went from 2% to 31% in a matter of a couple of decades. During this time, knowledge-based programs were started to teach about pharmacological effects, causes of addiction, health effects of drug use, and legal penalties. There is no evidence that information alone causes changes in behavior. You can't tell somebody something and that sticks. You never know that that's working. So, especially with these problems. Now, of course, if you're in an educational program and I give you a select information, then that will stick. But this is something that people wanted to do, therefore they were less likely to accept a different idea than their own. Skill building and resiliency programs, as more research was being done, it was discovered that there were obvious psychological and developmental factors that predisposed select individuals to drug use. Programs aimed at these individuals targeted social skills that might protect the individual from experimentation. One of the fears, of course, was that that people were starting to use tobacco, alcohol, and marijuana and maybe harder drugs because of peer pressure. So one of the things we tried to do was to teach them to be resilient and to stay away from peer pressure. Skills that address risk factors that might lead to drug abuse included general competency building, training in self-esteem, socially acceptable behavior, decision-making, self-assertion, problem-solving, vocational skills. coping or resistance skills, developing self-reliance, confidence in yourself, and inner resources. Reinforcing protective factors and resiliency build on natural strengths that people already have available. Their optimism, empathy, insight, intellectual competence, self-esteem, direction or purpose in life, determination, supportive friends and family, opportunities to belong to meaningful groups. It was really kind of interesting. Over the weekend, my grandson came over and we watched a movie called Turning Red. And it was interesting because in the movie, of course, this is a Pixar movie and it's a cartoon. But in the movie, you saw different social groups interacting, and the social groups were probably more important than anything else, than their families, than logical thought. All of that stuff went out the window. And it was their social groups that were the most important things to them. And that's what we're talking about here: optimism, empathy, insight, intellectual competence. All of these things need to be reinforced. And we need to explain to people that they have the power to either do something or not do something. And they're the ones that should be making that decision, whether they should do it or not. And that's a skill building and resiliency program. Skill building and resiliency programs address and reverse risk factors. Risk factors associated with future substance use disorders should be examined, with the focus being to seek strategies to minimize their development. Early aggressive oppositional disorder, poverty, lack of parental supervision, dysfunctional drug abusing peers, and that's what this picture is, dysfunctional drug abusing peers. These are all problems, potentially, these are all family problems or social problems that can lead to drug use, early aggressive oppositional disorder. So you become an individual that doesn't listen to what other people say early in life, growing up in a poor neighborhood, a lack of parental supervision, of course, and then your peers, and these guys look like they're drinking 7-Up. No, that's supposed to be beer in a green bottle. So what beer comes in a green bottle? What is it? Slippery Rock? Is that what it is? I can't remember. Anyway, I can remember people used to go to Pennsylvania. What is that stuff? Oh, I don't know. Pennsylvania. They used to go to Pennsylvania and get this really strange beer, and it came in green bottles. I never drank any because I don't like the taste of beer, but what was that stuff? It'll come to me in a minute. Skill building and support system development, endeavoring to reduce stress for students, which should decrease the need for drug and alcohol abuse. Changing the environment. One early target for concentration is the social and environmental influences that lead to drug use. Family values, peer group values, practices in schools. One of the things that can keep you away from drugs or to lead you to drugs is the friends that you select, or the people that select you as their friends. If they do negative things, then potentially you'll do negative things to be part of their group. If they do positive things, then maybe you'll do positive things to be part of their group. And of course, that was what was in the story, Turning Red. She's in a group of high achievers, so that is who she is. This is an attempt to get the entire neighborhood to take responsibility for preventing substance abuse by assessing the needs of the community, coordinating existing services, changing laws and public policy to reduce availability, increasing funding for family, school, and community prevention, community-wide training and planning. And of course, this all has to do with government money, state money coming in. In your case, of course, it would be tribal money coming in. The public health model for prevention sees addiction as a disease. The user is a genetically predisposed host. The environment contributes to the problem. The drug is introduced, causing the disease. Prevention involves disrupting the relationship between one or more of these factors. The family approach, this approach sees addiction stemming from family dynamics. Families are bolstered through family support, skills training, therapy, parenting programs. This approach focuses on the family rather than the environment. And what do we have here? We have who's smoking? Mom's smoking. There's her cigarettes. This is mom's wine. It's white wine. And this looks like dad's drink, whatever it is. It looks like probably it's vodka. So here we are sitting around watching television. The kids are seeing this. Mom smoking and drinking her white wine, and dad is drinking his vodka something or other. I hope that's not a whole glass full of vodka. That's a lot of vodka to be drinking. Supply reduction seeks to decrease drug abuse by reducing the availability of drugs and is the responsibility of state and local police departments. Department of Justice, the FBI, the Bureau of Prisons, INS, the Immigration and Naturalization Services, DEA, Drug Enforcement Agency, Treasury Department, ATF, Alcohol, Tobacco, and Firearms, IRS is the Internal Revenue Service, and Customs Service, Department of Transportation, and DOD. The responsible agencies reduce drug supplies by interdicting drug smugglers, manning law enforcement activities at border crossings, limiting the supply of precursor chemicals, disrupting criminal gangs and organized crime, passing more severe laws, increasing community police officers, disrupting money laundering and seizing assets, supporting local and state police in high-volume drug areas, supporting the anti-drug efforts of foreign countries, enacting treaties to work toward supply reduction. Drug laws in the United States have evolved to curtail the supply and use of illicit drugs. Long prison terms and forfeiture of assets have been used to discourage suppliers and manufacturers of drugs. Users are discouraged by facing stiffer and increased jail time. Possession of paraphernalia adds to the length of time spent in jail. Many states, including California, enacted three-strike laws in the 1980s, which mandated life imprisonment if an individual committed 3 felonies in their lifetime. Since 1980, prison populations have tripled. 55% of the inmates in federal prison were convicted of drug offenses. If you count felonies committed to support drug habits, the percentage increases to 60 to 80% of the people in prison are due to drug charges. Over half the inmates incarcerated admit to using drugs while they committed their offense. The percentage of teenagers is even higher. A great deal of money has been spent on supply reduction. Advocates estimate that it has resulted in a 10 to 15% supply reduction. The severe penalties have resulted in a delay impulse to use. It has opened up treatment. It has kept people in treatment. Detractors of the policy complain of the minor impact on supply. These individuals support a more demand reduction approach. Demand reduction involves the 3 tiers of prevention: primary by promoting abstinence, help young people refuse drugs, delay the age of first use, encourage healthy non-drug alternatives. The age of first use is the strongest predictor of drug or alcohol use. Individuals who experiment before age 12 have a 4 to 5 times likelihood of further drug use, and that's the primary tier of drug reduction, demand reduction. Sorry, I needed a drink. Secondary prevention seeks to halt drug use once it has begun. This tier of prevention adds intervention to the primary strategies of education and skill building. The biggest problem with this program is denial by the user and their concealment of use, making them difficult to identify. Another problem with this tier of prevention is that there is a lag phase between the first drug use and the physical and emotional problems. The user feels that the educational programs are overstated. And I've had this argument over and over and over and over again with people. It doesn't really hurt you. Well, yeah, you've only been using for a year. If you use it for the next 5 years, then you're going to see a problem. And of course, that's usually what happens. I had a friend who smoked tobacco, and I kept telling him, "Look, you're already having problems. I can see. Look at your nail beds. You're not getting enough oxygen into your system. Look at my fingernails and look at your fingernails. His were purple, and of course mine are nice and pink, rosy pink, because I don't smoke cigarettes. And of course it didn't register with him that he was going to kill him. He was killing himself. So when was the first year I taught at Dene? 2016. 2016, he had a heart attack. He had the same heart attack I did. I had a heart attack in 2010. He had a heart attack in 2016. My heart attack had to do with I had just gotten fired. I was really upset. What else was a reason? Oh, the other reason was because my blood vessels in my heart I lift weights, so because of that, they had formed these extra loops that most people don't have. And when I was so upset about my being fired, those some of those loops collapsed and caused a reduction of the amount of blood that was getting into my body. But of course, I don't smoke, I don't drink, I don't, and I exercise on a relatively regular basis. So when I had my heart attack, even though I had only 7% blood flow, I had 93% occlusion. I was still able to survive, and the reason I was is because I was healthy and I hadn't done any of these things. When you smoke tobacco, it's a vasoconstrictor, so your blood vessels close up, and because they do that, they're not getting enough blood to the portions of your body. So when I had my heart attack, because of my healthy lifestyle, I was able to survive it, despite the fact I had 93% occlusion. My friend had the same heart attack I did in almost exactly the same place, and his occlusion was less than mine. He still had 10% blood flow. He only had a 90% occlusion, 87 to 90% occlusion. But he died, and the reason he died is because he smoked cigarettes, and because his body wasn't he didn't exercise, so his body wasn't used to expanding those blood vessels when they were needed, and he died. Tertiary prevention seeks to provide treatment for the user to restore them to health. Compulsive drug use is addressed through group intervention, focusing on detoxification, abstinence, and recovery. Cue extinction therapy that desensitizes the user to people, places, and things that are triggers to use. Family therapy, group psychotherapy, or residential treatment, instruction in relapse prevention and life management skills, psychopharmacological strategies, promotion of healthy lifestyles, development of support and aftercare programs. And these are 12-step programs that we're talking about. Tertiary programs result in decreased use of abstinence in 40 to 50% of the cases, 74% reduction in crime, 2,500,000 people receive treatment nationwide. 21,700,000 people are estimated to need treatment nationwide, but only 2,500,000 of those are able to get it. That's about 1/10 of the people that actually need it. Not all programs seek abstinence. Harm reduction programs recognize the recovery is difficult, and many will relapse before they're able to live their lives drug-free. This technique focuses on minimizing the personal and social problems caused by drugs. 3 harm reduction programs, needle exchange programs to reduce the spread of HIV and hepatitis C, bleach distribution programs, to reduce the spread of HIV and hepatitis C, legal drug substitution for illegal drugs, so the replacement of heroin with methadone is a good example of the drug exchange program. And this is an answer to a question on your quiz. What are the three harm reduction programs? Harm reduction programs have also proposed some controversial ideas. They accept the fact that people will experiment with drugs and they want to educate them to use drugs responsibly. Decriminalizing or even legalizing illegal drugs, treat addicts by reducing their usage to a manageable level rather than seek abstinence, allow addicts to design their own intervention and treatment programs. And of course, I don't agree with any of these ideas. Some of the most lucrative advertising on television is advertising for alcoholic beverages. Before 1996, hard liquor was not advertised on television, only beer. The idea from the temperance argument of the 19th century was that replacing hard liquor with beer would reduce drunkenness and the destruction of alcohol. However, more people die from cirrhosis of the liver caused by beer than cirrhosis caused by hard liquor. That's something that you need to remember. Damage done by legal drugs cause more damage to society than illegal drugs. Alcohol, tobacco, prescription drugs, advertising for these drugs brings new users into the fold every year. Facts to remember about prevention: there are no quick fixes. Prevention will never be complete because there will always be new potential users to convince. Prevention campaigns become progressively more difficult in time because they have already reached the easy cells. No single approach has been shown to work consistently. Legalization of marijuana in the medical form of marijuana will make it more and more difficult to control all drugs. When we see depictions of drug addicts in the media, they are often portrayed as weak, bad, stupid, crazy, immoral, poor, and disenfranchised. 1/3 of the homeless have a drug or alcohol problem. This only represents 5% of the addicts in the United States. The truth is that whites are the most likely to have either a drug or alcohol problem. African Americans are just as likely as whites to have a drug problem, but the least likely to have an alcohol problem. Hispanics are the least likely to have a drug problem. People in low-income areas are less likely to receive treatment and more likely to be incarcerated for their drug use. More affluent people are more likely to receive treatment and probation. And this is one of the reasons why they don't think that there's a reason to throw money at the problem. Why? Because they're okay and their kids are okay. It's your kids that are the problem, and they can't get treatment. You don't have the money. 53% of the individuals in prison for drug crimes are African American. 26% of those in prison for drug crimes are white, even though it's the white people that are really the problem. Among the highest paid occupation in the United States, physicians, they are as likely to be addicted as the general population, though they are more likely to be addicted to prescription drugs. Members of Mensa and gifted high school students have high rates of addiction. Mensa is you have to have an IQ over 140 to be in Mensa. So this is for really smart people. Members of the clergy have high rates of alcoholism. While addiction rates fluctuate with attempts to curtail use, over the last 40 years, the age of addicts has declined with the age of first use. Between 1991 and 2005, the number of 8th through 10th graders who used marijuana increased 60%. Juvenile arrestees testing positive for drugs other than alcohol ranged from 48 to 65% in 2005. It is estimated that 18.6% of infants are exposed to alcohol in the womb. 4.5% of fetuses are exposed to cocaine. 17.4% of fetuses are exposed to tobacco. Fetal alcohol syndrome is the third most common birth defect and the leading cause of intellectual disability in the United States. Drug use during pregnancy can create nutritional and obstetrical complications: anemia, sexually transmitted diseases, diabetes, high blood pressure, neurological damage, weakened immune system, poor nutrition, hepatitis C exposure, endocarditis, HIV and AIDS exposure. 80% of infants born with HIV in the United States were born to mothers who are IV drug users or the partners of men who are IV drug users. Worldwide, the figure is 90%. Unfortunately, the life expectancy of a child born with HIV is only 2 years. With AZT treatment for the pregnant mother, rates of HIV infection dropped from 25% to 8%. Pregnant addicts often live chaotic lifestyles that don't afford time or the wherewithal to seek or accept prenatal care or medical intervention. When the addict is an adolescent, the individual is at greater risk and even less likely to seek treatment. Other problems are likely because of her physical, emotional, and behavioral immaturity. Besides the effect of the drug on the fetus, the mother's toxic environment often has deleterious effects on the fetus and the mother: poor nutrition, blood-borne infections, domestic violence, and STDs, sexually transmitted diseases. And of course, this is domestic violence. Most psychoactive substances readily cross a placental barrier, meaning that the tiny infant is exposed to the same drugs at the same level as the mother. After birth, the drugs will be passed to the baby in the mother's breast milk. Because of the excessive organ and brain development, the 12 weeks, the first trimester, is the most critical period in the baby's life. Drugs used during this period can change the baby both physically and mentally. However, since the brain continues to grow throughout gestation, neurological damage can be done at any juncture during gestation. If heroin or cocaine is used during the last trimester, they might cause premature birth. If the baby is born after the mother has used drugs on a regular basis, the neonatal period will be fraught with intoxication, withdrawal, and eventually developmental or learning delays. If the infant is given concentrated care after birth, they will manage to catch up with their non-drug exposed peers, potentially by toddlerhood. Alcohol has one of the most devastating effects on a fetus of all the drugs. The effects of alcohol have been studied more than any other psychoactive substance because of its prevalence and the general acceptability of the drug. When a mother drinks during pregnancy, the possible effects on the fetus are referred to as FASD, fetal alcohol spectrum disorder. The most severe form of FASD is fetal alcohol syndrome. FAS is characterized by physical abnormalities, mental abnormalities, behavioral abnormalities. These babies are born to mothers who drank heavily during their pregnancy. And as I told you, when I was working in Omaha at St. Joseph Hospital in Omaha, we had a wing of the hospital that belonged to Boys Town Institute, where they were doing research with FAS, fetal alcohol syndrome. Fascinating stuff. And like I said, the people used to come down. We used to borrow stuff from them, and they would borrow stuff from us from time to time. And when they came down, of course, they liked to talk about what was going on in the institute and how they were doing and what they were discovering. And I was shocked to discover that alcohol has an affinity for fetal brain tissue. But that's what they discovered. Growth of the FAS fetus occurs in the womb. Reduced height, reduced weight, reduced head circumference, reduced brain growth, reduced brain size, facial deformities, shortened eyelids, thin upper lip, flattened midface, shallow groove in the upper lip, and there's a shallow groove right there. Heart problems, limb problems, delayed intellectual development, neurological abnormalities, behavioral problems, visual problems, hearing loss, balance, and gait problems. Part of FASD are less severe disorders, alcohol-related neurodevelopmental disorders, ARND, alcohol-related birth defects, ARBD. Worldwide, FAS affects as many as 2.9 out of every 1,000 births. In the United States, the rate is 2 for every 1,000 births. Among African Americans, the rate is 6 for every 1,000 births. Asians, Hispanics, and whites have rates between 1 to 2 for every 1,000 births. American Indians have rates between 10 and 30 per 1,000 births. And a lot of this has to do with where the individual is and how acceptable alcohol is in that area. Northern Plains Indians tend to have the highest rates of FAS. As a matter of fact, FAS was discovered on the Rosebud Reservation, if I'm not mistaken, in South Dakota. And it was discovered in Omaha. Rosebud is in South Dakota, is on top of Nebraska, and the hospitals where I worked, we were a focal point for anybody that had a severe problem. So we serviced western Iowa, all of Nebraska, of course, part of Kansas, and part of South Dakota. And because of that, it was discovered in Omaha, that FAS was discovered in Omaha. In one study of FAS adolescents and adults, it was discovered that all of them had been physically and sexually abused, 60% of the abuse occurring before adulthood. The individuals averaged 6 diagnosable mental illnesses. Select ones had 10 or more mental illnesses. Cocaine and amphetamines are used by 558,000 women in the United States every year, with most of them falling into the reproductively viable range. In the 1980s, when cocaine use was at its peak, it was estimated that 4.5% of all babies born in the United States were exposed to cocaine in the womb. In the inner city hospitals where cocaine use was more prevalent, the percentages ranged from 15 to 25%. And lucky me, I was working in Omaha in the 1980s, and I saw this sadly on a daily basis. We had a neonatal intensive care unit at Children's Hospital where I worked, and probably 80% of the babies that we saw were due to cocaine toxicity. The effects of stimulants, and one of the things that we don't even talk about, one of the things we don't talk about is that cocaine really changes. The more you use, of course, the worse it is, but cocaine really changes the structure, the bodily structure of fetuses. We had fetuses, well, I'm not going to give you the gory details, but we had fetuses that had no possibility of survival because of the placement of their organs and some of the strange things that these ladies were doing. And a lot of them didn't survive because of these organ placement problems that they had. The effects of stimulants, increased heart rate, constricted blood vessels, affects not only the mother but the unborn fetus. For the fetus, the constricted blood vessels results in restricted blood flow, restricted nutrients, restricted oxygen. This retards development. This retards development. So even if you carry the infant for 9 months, the probability of them coming out as a 7.5-pound baby is not very good. Most of these babies are low birth weight. A lot of them have, like I said, organ problems, organ development problems. For habitual users, the effects can be more pronounced. In extreme cases, the increased blood pressure may cause the placenta to separate from the uterine wall, resulting in spontaneous abortion. Excessive use of stimulants can raise the fetus's blood pressure, causing a stroke in the infant. Using in the third trimester can result in extreme activity in the fetus, causing uterine contractions and premature labor. Withdrawal for the fetus involves several weeks of extreme agitation, increased respiration, hyperactivity, possible seizure. Effects last into the child's second year with lifelong disability rates up 33%. That's 1/3 of these children will never, ever, ever be normal. Since opioid use tends to be more continuous than the binge use of stimulants, the effects are greater. Problems include severe infections from IV drug use for the mother, fetal growth retardation, miscarriage, stillbirth, separation of the placenta from the uterus. Babies born to heroin addicts are often premature, smaller, and weaker. And of course, I was working in the hospital during the cocaine epidemic. Heroin wasn't that opiates were not that common, so we didn't really see a lot of these. Luckily for me, I have a niece that was a heroin addict, so I have more information about this stuff. These infants have abnormal sleep patterns that leads to a 600% increase in SIDS deaths. 60 to 80% of babies born to opioid addicted mothers go through withdrawals 2 to 3 days after they are born. Hyperactivity, incessant high pitched drugs, crying, increased muscle tone, irregular sleep patterns, increased respiration, poor suckling, failure to thrive, irritability, sweating, tremors, diarrhea, sneezing, vomiting, and of course, many of them don't make it. Marijuana is used by 5 to 17% of pregnant women during their pregnancy. A longitudinal study of marijuana exposed fetuses in Canada showed that poor short-term memory and verbal reasoning at age 3, continued poor memory through childhood, lowered verbal performance through childhood, impulsive hyperactive behavior, conduct problems, distractibility, poor executive function. This was in Canada. Now, why in the world would we do this in Canada instead of the United States? And the reason is because over 50 years ago, the Canadians decriminalized marijuana use. So there was a lot of marijuana use in Canada, and it was a lot easier to find women who had used marijuana in Canada, and this is what they discovered. Now we're legalizing it in the United States. 20 states have legalized marijuana. So we'll see more of this in the United States, and I am really happy that I do not live in any of the states where they have legalized marijuana, and I certainly am happy that I don't work in medicine anymore, so that I have to see this. I'm sorry that I was working in medicine during the HIV epidemic and the cocaine epidemic. Because it was not a lot of fun. The problem with marijuana is the same as the problem with any other drug smoked. It decreases your oxygen. It irritated alveoli and bronchi in the lungs. Decreased weight, withdrawals, abnormal responses to visual stimuli, increased tremulousness, easily startled, high-pitched cry. Drug fetal effects, category A, vitamins other than vitamin A, no fetal risks. Category B, acetaminophen and ibuprofen, no fetal risks. Category C, most medications, no fetal risks. Category D, anti-seizure benzodiazepines and tetracycline. Tetracycline is a antibiotic. It's what they use for acne. Fetal risk, but the risks are considered appropriate to the need of the mother. Category X, teratogenic, things such as vitamin A and Accutane. Accutane is a heavy dose of tetracycline. Fetal risks are too great for the benefits. So if you're taking heavy doses of vitamin A or you're on Accutane for acne, you got to stop. You got to stop when you're pregnant. Any medication prescribed for a pregnant woman should be closely monitored. Use of NSAIDs, nonsteroidal anti-inflammatory drugs, can elevate the pregnant mother's blood pressure. Benzodiazepines can accumulate in the fetus's blood, even at safe levels for the mother. Because of the fetus's smaller system, it will take longer for the infant to clear the drugs from his system and may be born addicted. Because of the slowness in clearing the infant's system, the baby will be born with withdrawals that may persist for weeks. And it took 6 weeks for my great nephew to get cleaned up. 6 weeks. He was going through withdrawals for 6 weeks. And now, evidently, he's very bright. That's not the problem. The problem is he has rage issues, and sometimes he just gets so angry he starts throwing things. And you never know when that's going to be. At the turn of the 20th century, women rarely smoked. In the 1920s, only 5% of pregnant women smoked. Pregnant women smoking peaked in 1997 at 28.2%. In 2005, only 22.5% of pregnant women smoked during their pregnancy. 17% of the women smoked cigarettes. 8.82% smoked right up to the time they gave birth. The highest rates were among African Americans at 20.12%. The second highest rate was among whites at 14.2%. Cigarettes are especially dangerous because of the nicotine and carbon monoxide found in the smoke, along with 2,000 other compounds. Both carbon monoxide and nicotine cross the placental barrier and reduce fetal oxygen supplies. Women who smoke or come in contact with secondhand smoke are in greater risk of premature delivery. Heavy smoking mothers are twice as likely to miscarry or have spontaneous abortions. Babies born to heavy smokers average a birth weight of 7 ounces less, with a smaller head circumference and about an inch shorter. With heavy smokers, there is a higher incidence of cleft palate, congenital heart defects, minor nerve and brain defects, higher incidence of sudden infant death syndrome, weaker sucking reflex, depressed immune system, more respiratory infections. Now you'd ask yourself, why in the world is all this taking place? Are they just making all this stuff up? And the answer is, when you smoke a cigarette, one of the things that happens is that it's a vasoconstrictor, so the blood flow is constricted. And the other thing is that you're putting nicotine and carbon monoxide into the baby's system. Now, why in the world would that cause a cleft palate? One of the things that happens, and you may not understand how humans are put together, but the two halves of your face, the two halves of your head develop separately. And in order for the baby to have an attractive face or a symmetrical face, these two halves have to meet right there in the middle. If you feel if you stick your tongue up under your lip, under your upper lip, you can feel that there's a bunch of skin in there. That is where the two halves of your face came together. Now, if you're a smoker, if you smoke cigarettes and you smoke cigarettes while this is happening, all these two halves are coming together, then potentially what will happen is they won't come together completely, and that causes a cleft palate. And the same thing with all these other problems, the congenital heart defects. Now, why in the world does this happen? Because when that was supposed to be repairing itself, when it was supposed to be correctly being put together, you smoked a cigarette and it didn't happen. Caffeine is a common drug taken in by pregnant women in tea, coffee, and soda pop. In one study, 75% of the babies born had caffeine in their system at birth. Infants tend to have lower tolerance for caffeine than adults do. Caffeine seems to have no long-lasting effects on the child, though physicians warn pregnant women away from its use during pregnancy. And much to my daughter's benefit, or my grandson's benefit, my daughter went off of caffeine as soon as she discovered that she was pregnant. Actually, she went off caffeine before she became pregnant, when she was trying to get pregnant. And you have to give my daughter all the accolades in the world because she did that. She drank Diet Pepsi by the bucket load. So it was tough for her during her pregnancy. She had to stay away from caffeine, and she had to stay away from alcohol, which she drank before pregnancy, but she did a really good job of staying away from the things that could potentially hurt her son, my grandson, and I appreciate that. Prevention of damage should start as soon as the woman discovers that she is pregnant. Physicians will ask the woman the 4 Ps. The parents, did either the woman's parents have a problem with drugs or alcohol? Partner, does the woman's partner have a problem with alcohol or drugs? Past, has the woman ever drunk beer, wine, or liquor? Pregnancy, in the month before the woman knew that she was pregnant, did she smoke cigarettes, take drugs, or drink beer, wine, or liquor? If necessary, the woman can be treated for her dependence. And of course, that's what they tried to do with my niece, my great niece, and they were unsuccessful. The most frequently abused drugs, 46.5% among high school seniors. Tobacco, 21.6%. Marijuana, 18.3%. Smokeless tobacco, 6.1%. Painkillers, 3.8%. Amphetamines, 3.7%. Tranquilizers, 2.7%. Cocaine, 2.5%. Inhalants, 1.5%. Hallucinogens, 1.5%. MDMA, 1.3%. Steroids, 1.1%. Heroin, 0.4%. And any illicit drugs, 22.1%. In the last 30 years, tobacco and alcohol use has actually declined while marijuana use has primarily stayed the same. School environment has the greatest influence on drug and alcohol use. If the individual can reach the age of 21 without smoking and drinking, they probably never will. Of the people who experiment with alcohol or tobacco, more susceptible to peer pressure maybe, 85.7% are still smoking in the 12th grade. If they have been drunk sometime in high school, 83.3% are still getting drunk. If they have ever tried marijuana, 76.4% are still toking. Adolescents who use marijuana weekly are 6 times likelier to cut class or to skip school. One of the greatest oxymorons of adolescence is that while they think of their own thoughts as beyond question and their lives as invulnerable, they commit some of the most ill-advised acts that can sometimes lead to death. Intoxication, intoxication in driving, intoxication in having sex. 70% of teen suicides involve alcohol. 50% of date rapes involve alcohol. 40% of drownings involve alcohol. Alcohol and drug use among adolescents has a great deal to do with crime. More than half of the juvenile males arrested test positive for 1 or more illegal drugs. Marijuana is the most frequently found drug among these individuals. No matter what you say about marijuana, it still doesn't keep them from committing crimes. One of the major reasons people use psychoactive substances is to delay taking care of their problems. When this happens with an adolescent, they may not learn to deal with life's conflicts until they are deep into adulthood. They have prolonged the maturation process. Factors that lead an adolescent to use psychoactive substances: being subject to physical, sexual, or emotional abuse, being mentally or emotionally disturbed, lacking self-esteem, peer group encouragement to use drugs, inconsistent discipline where drug use is tolerated, dropping out of school, getting caught in the juvenile justice system, getting pregnant, living in poverty, lacking alternative activities, being in a school that does not control drug problems. Factors that help children avoid drugs: strong sense of family participation and involvement, family position on drugs, alcohol, and sex that the child can adopt as their own, strong spiritual sense and community involvement, attachment to a clean and sober adult role model. There are programs that have been developed to help school-age children K through 12 stay away from drugs and alcohol. the DARE program, the Drug Abuse Resistance Education Program, 16 to 17-week sessions conducted by a uniformed police officer to the 5th and 6th graders. The Dare to Be You, the DTBY, the Family Matter, Lion's Quest Skills for Adolescents, and interestingly, Lion's Quest, I did Lion's Quest research when I was when my wife was stationed in California. She was working with the RAND Corporation, and the RAND Corporation was doing research for Lion's Quest, and we gave children, we gave junior high students tests trying to find out how much information they had about drugs. And that's what I did. I went to the schools around the Los Angeles area, the junior high schools, and we gave them these tests, which was really fascinating. Multi-systematic therapy, MST, New Beginnings program, Project Towards No Drug Abuse, Seeking Safety, Life skills training, increases social skills to help resist peer pressure. All the programs to help prevent drug abuse are similar. They all involve a coordinated effort among family members, teachers, and other school officials. These school-based programs tend to teach life skills, resistance education, and normative education. A lot of people don't realize that not drinking is normal. Drinking is statistically, it happens less than drinking does. Normative education aims at correcting erroneous beliefs about the prevalence and the acceptability of alcohol and drug use among an individual's peers. Family-focused primary prevention is a necessary adjunct to any school-based program. Experimentation, social use, habituation, and abuse usually begin in junior high, the 6th, 7th, and 8th grades. Because of this proclivity, primary prevention needs to continue while secondary prevention is put in place to deal with those who didn't get the message. School personnel and families should be trained to recognize drug use and how to deal with the consequences. For those students who begin abusing drugs on a regular basis, treatment must be sought to reduce the probability of a lifetime of abuse. Such a program as the Positive Behavioral Intervention supports adjustments to the environment to reduce the problem, building general competencies and teaching replacement skills, implementing consequences to promote positive behaviors and deter problems, crisis management, or relapse plan. 1 in 4 children in the United States is exposed to alcohol abuse or dependence in their family. And that's an answer to a question on your quiz. Sorry, I was getting a drink. These children will be affected by alcohol even when they don't use. These children may play different roles in their family. Hero or model child tries to bring pride to the family. Problem child demands attention and is most likely to use psychoactive substances. The lost child, they are shy and they sidestep problems by avoiding family and social activities. And the mascot or family clown, they try to ease tension in a dysfunctional family by being funny or cute. They have a hard time growing up. Many alcoholic, and that's an answer to a question on your quiz too, by the way. Many alcoholic beverage companies target their advertising toward college freshmen, as establishing brand loyalty may generate as much as $20,000 to $50,000 revenue over Slippery Rock. That's the name of that beer. It was Slippery Rock. There's a Slippery Rock in Pennsylvania, and evidently there they brew beer. This beer, I guess. I've never tasted it, but I understand it's not the best tasting beer in the world. Anyway, and it comes in green bottles. So there were certain fraternities on my campus where Slippery Rock was the only beer they drank. So what are we talking about? So if you have brand loyalty, then that may generate as much as $20,000 to $50,000 revenue over the individual's lifetime. 49% of full-time college students binge drink and or abuse prescription and legal drugs. This is 2.5 times the amount of abuse found in the general population. Statistics on college students has varying degrees of positive and negative. Daily smoking dropped from 15% in 1993 to 12% in 2005. Fraternity and sorority members are more likely to drink than non-members, 88% versus 67%. Binge drinking, 64% versus 37%. Driving drunk, 33% versus 21%. Using marijuana, 21% versus 16%. And smoking, 26% versus 21%. Only 6% of addicted college students seek help. 78% of college students who use illicit drugs have sex compared to 44% of those who never use drugs. Psychoactive substances do have a heavy impact on our college campuses. 1,717 deaths in 2007 from alcohol-related injuries. 97,000 victims of alcohol-related rape or sexual assault. 696 assaults by another student who has been binge drinking. In 2002, the federal government legislated to deny college students federal aid if they had a drug conviction on their record. Of the 10,437,000 who applied, 41% were denied, 41,000% were denied aid, while an equal number were waived and who had completed a drug treatment program. Even the non-drinkers are affected by the drinkers. In a study of a campus where over 50% of the campus were binge drinkers, 87% of the non-drinking other students reported being victims of assault, being victims of unwanted sexual advances, having sleep interrupted, having study interrupted, suffering property damage, having to care for a drunken student, having to clean up after a drunken student, having impaired quality of life because of the drinking. And I was never a victim of assault. It was an all-male college, so I was never accosted sexually. But I did have my sleep interrupted, my study interrupted. I didn't have any of my property damage, but there was property damage on the campus. Having to care for a drunken student, oh my God, that's such a pain in the butt. Having to clean up after a drunken student, that is also a pain in the butt. And having impaired quality of life because of the drinking. I would say that all of those are true as far as I was concerned. Drinking and drug experimentation are seen by some as a rite of passage for college students. However, one approach to the control of college drinking is a normative approach where the myths of rampant drinking are debunked. For example, 68% of college students thought that their peers thought frequent intoxication was acceptable, while only actually 14% did. Within 18 months, within disseminating normative information, one college campus found 16% reduction in drinking to get drunk, 21% reduction in frequent heavy drinking, 31% reduction in missed classes, 36% reduction in property damage, 40% reduction in unprotected sex. One of the things that you need to remember or to think about is that when people leave high school, in high school everybody is in like lockstep with each other. Everybody wants to be like everybody else. But in college, of course, you're becoming your own person. So it is very likely and logical for people to not follow the peer pressure in college. It makes more sense. You're starting to become your own person, and therefore, by the time you graduate from college, you should have your own brain instead of the clone brain that you had when you were in high school. Means of controlling alcohol use: regulate campus drinking. 25% of campuses ban beer. 32% prohibit liquor on campus. 98% prohibit kegs in dorms. Provide alcohol, tobacco, and drug-free dorms, wellness halls Two-thirds of the campuses offer such dorms. Prohibit alcohol at campus events and fraternities, sorority parties, announce and enforce campus alcohol and drug policies, work with the local community to make sure that alcohol is not served to minors, strengthen academic requirements. Means of controlling alcohol use on college campuses: schedule more classes on Friday, keep the library and recreational facilities open longer, prevent alcohol promotions on campus, notify parents when students run afoul of the drug and alcohol regulations, provide server training for bartenders at college-sponsored functions, ban alcoholic beverages advertising in college newspapers. 50% of campuses ban such advertising. Controlling alcohol use on college campuses, integrate substance abuse education into the curriculum, maintain a substance abuse officer to oversee on-campus use and abuse, join a higher education prevention consortia. 90 such consortia do exist. Create programs to work with the neighborhood and community, initiate early detection, intervention, enforcement, and referral. Studies show that a good drug education program will actually increase the level of experimentation but decrease abuse. Bad education will actually increase abuse. Studies show that as most college students mature, their alcohol and drug use becomes more sensible. People take psychoactive substances either to enhance some aspect of their sexual sensation or not realizing that it will interfere with their sexual sensations. Select psychoactive substances can replace normal sexual emotions, meaning that the emotions will seem to be there when they are not. The intimacy, the comfort, the love for one's children, and the release from anxiety. I love sex and drugs, a glass or two of wine to get in the mood, a cigarette after sex, a popper to intensify an erection or orgasm, amphetamines to delay ejaculation, marijuana to enhance the newness of a situation, ecstasy to increase empathy. Drugs are desirable when the individual feels a physical, social, or emotional deficit, such as aging, shyness, lack of confidence, diminished desire, diminished abilities. Unfortunately, the same drugs, when used long-term, may create the reverse effect: lack of sexual interest, physical depression, inability to achieve an erection, inability to achieve an orgasm. Drugs may trigger sexual aggression, sexual harassment, rape, child molestation, high-risk sexual behavior. Drugs trigger rape. How was that? Once upon a time, I lived in an area, and this individual, I was teaching this lady who was married to this guy, and one night he came home drunk on whiskey, or no, he was at his cousin's house, and he was drunk on whiskey, and he, while he was inebriated, and when he claimed he didn't know what he was doing, he raped his 12-year-old 12-year-old nephew. He had to leave. He had to leave the area. Everybody had to leave the area. He left the area. Of course, my student had to leave right in the middle of the semester. They took their 3 children with them. The mother of the lady who was my student, she had to leave the area as well. The 3 main effects of psychoactive drugs on sexual desire are desire, excitation, and orgasm. They do this by releasing hormones, affecting blood flow, affecting blood pressure, affecting nerve sensitivity, affecting muscle tension. Some examples of psychoactive interference with normal sexual activity: heroin desensitizes penile and vaginal nerve endings, making it you're not feeling as much as you would if you weren't on heroin. Alcohol diminishes spinal reflexes, decreasing sensitivity and erectile ability. Steroids increase testosterone, making the user more sexually aggressive. Cocaine and amphetamines release dopamine, which mirrors the release of dopamine during orgasm. Many drugs affect the hypothalamus, which can trigger unwanted hormonal changes. Chronic drug users combine sex and drugs to lower their inhibitions, to try to make themselves perform better, to increase their fantasies, to shield themselves from their sexuality, to remove themselves from emotional involvement. Alcohol effects on sexual function are directly related to blood alcohol levels. Women may use alcohol to lower their inhibitions, to increase sexual pleasure, to raise self-esteem and feelings of adequacy. However, with the increase of alcohol, there is actually less of a chance of orgasm. Women are more likely to drink to hide sexual dysfunction than men are. Engaging in sex seems to be something to do while drunk. For men, enough alcohol can actually prevent them from being able to have an erection, as it diminishes spinal reflexes, decreasing sensitivity and erectile ability. Alcohol also lowers testosterone levels while increasing the female hormone estradiol. Chronic male drinkers will have a greatly decreased testosterone and greatly increased estradiol, creating abnormalities in sex steroid metabolism. Men like alcohol because it anesthetizes the area of the brain that causes fight, flight, and fear, making them more aggressive. However, it does lower testosterone, making men more likely to act asexual. In one study of heavy drinkers, 60% reported being impotent. 60% reported being impotent. Amphetamines and cocaine have always been have had the reputation of being sexual enhancers, but this is especially true in the gay community because it increases your confidence, it prolongs erections, it increases endurance, and it intensifies orgasms. This is especially true of methamphetamine, which lasts longer in the individual's system. Amphetamines and cocaine can greatly intensify the pleasurable feelings that an individual gets from sex. Unfortunately, with continued use in sexual situations, the intensity lessens. As dysfunction begins, the individual will seek to use more and more of the drug to achieve normal sexual functioning. The drug will also intensify pre-existing sexual proclivities. If this is something as harmless as sexual inhibition, it will make the individual more confident. If the proclivity is pedophilia or rape, the drug can intensify these behaviors as well. While cocaine may work wonders for men when first used, with prolonged use, the effects may be unintended. Delayed ejaculation, decrease in sexual desire, difficulty achieving ejaculation. In women, cocaine may disrupt the menstrual cycle, may cause difficulty in achieving orgasm, may decrease desire. Smoking after sex has become a cliche for having had sex. In truth, long-term tobacco use is associated with a lower testosterone and erectile dysfunction. In women, it causes reduced fertility. The opioids are depressants and so may act to lower an individual's inhibitions when first used in concert with sex. However, with prolonged use, long-term users report impaired performance and a decrease in sexual desire. In one study, the degree of impotence among males was 39%, jumping to 53% when the individuals were actually using the drug. Some of the sedative hypnotics have been touted as sexual enhancers: benzodiazepines, barbiturates, and quaaludes. The reality is that the individual has lowered inhibitions, which makes it more likely that they will be willing to perform sexually. With prolonged use, the individual begins to suffer from sexual dysfunction and apathy towards sexual stimulation. Select sedative hypnotics have been used as date rape drugs. Rohypnol causes amnesia and lowered inhibitions that makes an individual less likely to resist a sexual assault. GHB lowers inhibition and makes sex more pleasurable. Too much can lead to sleep or even coma. The drug also has an amnestic effect. That's the GHB. Marijuana's effects have much to do with the attitude of the individual when smoking, much like LSD. In a pleasant social situation, like at a party or on a date, the drug will make people less inhibited and more relaxed, making it more likely that they will do things that they wouldn't do normally. Research looking at marijuana in a controlled setting found that the drug inhibited orgasm but not desire. The biggest problem with chronic marijuana use is the user does not learn to have sexual relations without being stoned. MDMA and MDA give their user a warm feeling toward others and induce a heightened sensual awareness. However, the heightened sensual awareness does not enhance the ability to have an erection. As well, orgasms are more difficult to achieve. Sexual excitement is unlikely when high on the drugs. If this response is going to occur, it is usually as the person is coming off the drug than when they are on the drug. Neither PCP or LSD are considered sensual drugs. As an anesthetic, PCP has been used to deaden the pain in select sexual practices in both the gay and heterosexual communities. LSD, as a matter of fact, no psychedelics are known as sexual enhancers. Nitrites are used in both the gay and straight communities as a vasodilator and a muscle relaxer. Users claim that nitrites prolong and enhance orgasmic sensations if used just prior to the orgasm. Like Viagra and other ED medications, erectile dysfunction medications, nitrites act as vasodilators, promoting penile erection. Nitrites also relax the anal sphincter muscles, supporting anal intercourse. Psychotropic medications often will interfere with sexual functioning. Tricyclic antidepressants have been linked to decreased desire, problems with erection, and delayed orgasm. SSRIs also caused delayed or inhibited orgasm and impaired erection abilities. Antipsychotics inhibit erectile function and ejaculation as well as desire. With heavy doses of lithium, desire decreases and individuals report having difficulty maintaining erections. Aphrodisiacs actually may not exist, though some drugs will enhance sexual situations. The erectile dysfunction medications, Viagra, Cialis, and Levitra, allow increased blood flow to the penis but do nothing for sexual desire. Spanish fly irritates the bladder and the urethra but does not actually increase desire. Human pheromones increase sexual desire and sexual stimulation, but only select pheromones work on select people. Yohimbine can enhance blood pressure and heart rate, increasing penile blood flow, but no desire. Drugs are often present in cases of sexual assault. 51% of victims reported using drugs or alcohol before the assault. 44% of the assailants used drugs or alcohol before the assault. Irrational or inappropriate desires may occur after alcohol lowers inhibitions and muddles rational thought. Stimulants make the user feel more confident and aggressive, making it more likely that a date will be assaulted. Sedatives lower inhibitions, making women more susceptible to assault. Marijuana makes users more suggestible to sexual activity. PCP and heroin make users less sensitive to pain, making it more likely that they will damage their partners during sex. Just last weekend actually, Tyler Hawkins died of it looks like a drug overdose. What did he have in his system? Wait a minute, he had opioids, he had THC, which is from marijuana. He had tricyclics and benzodiazepines. Tricyclic drugs are the antidepressants, tricyclic antidepressants, and he had benzodiazepines in his system. But they said that he had 10 different drugs in his system, but they've only mentioned 4 of them, or maybe he had different types. Anyway, he died. He died at age 50 years old. He was a drummer for the Foo Fighters. I'm sorry that he's dead, but my goodness gracious, Putting all four of those drugs in your system at the same time doesn't make a whole lot of sense. So maybe that was his problem. Right. Drug use peaked in the 1980s. Positive drug rates at work were 13.6% in 1988. By 2006, with actually more drug testing, the rate had dipped to 3.8%. The lower drug use levels at work may be due as much to drug users avoiding companies that drug test as drug usage at work declining. Estimates are that 8.2% of all workers use illegal drugs. 8.4% of full-time workers are heavy alcohol users. Contrary to the image of the addicts skulking around alleys to support their drug habit, 74.8% of addicts over 18 are employed as full-time or part-time employees. 80% of binge drinkers are employed. 62% of the people diagnosed with substance abuse disorder were employed. Unfortunately, substance abuse employees do not make good employees. They're late 3 to 14 times more often. They are absent 5 to 7 times more often. They make more mistakes than other employees. They tend to have a lower output. They are more likely to appear in a greater number of grievance hearings. They are 3 to 4 times more likely to have an accident on the job. They use 3 times more sick leave. They file workers' compensation 5 times more frequently. They overutilize health insurance along with their family. They cause premiums to increase for medical insurance. They endanger the health and well-being of coworkers. Just a point of reference, I haven't had a sick day since I was in the Air Force. And I got out in 1983. So there you go. The most common drug found in employees' samples, marijuana at 48.8%, cocaine 16.4%, amphetamines 9.3%, opiates 6.7%, benzodiazepines 5.4%. While I was in the Air Force, one of the things that I had to do was collect drug samples. It was one of my jobs. What a great job that was. 28% of people tested for cause tested positive. The area of the country that was the most likely to have positive drug tests was in the rural South. Something to remember if you're thinking of moving somewhere. Employee assistance programs are programs established to help employees become better employees by providing treatment and counseling when needed. 45% of all employees in the United States are covered by EAPs. 70% of all employees working for organizations with more than 500 employees are covered by EAPs. EAPs do work. Northrop saw a 43% increase in production from the first 100 employees they sent to an alcohol treatment program. Employees of the Philadelphia Police Department who went through treatment reduced their sick days by 38% and their injury days by 62%. Providing EAPs for their employees at the Oldsmobile plant in Lansing reduced their lost work hours by 49%, healthcare claims by 29%, sick leaves by 56%, grievances by 78%, disciplinary problems by 63%, and accidents by 82%. And of course, Oldsmobile is no longer made. They closed down the Oldsmobile production plants during the Obama administration. And he was president from 2009 through 2016. There are several types of EAPs based on financial needs. Internal in-house programs are found in large companies who can afford the expense. Fixed fee contracts, the company contracts at a set fee for any programs needed. Fee-for-service contracts, the company contracts with an outside EAP on an as-needed basis. Consortia, smaller employees get together to contract with an outside EAP service. Peer-based programs, peers and coworkers provide the needed services. The military has been at the forefront of drug testing since the war in Vietnam. In the late 1970s, drug testing in Europe peaked at 1 in 3 soldiers testing positive for illicit drugs. And I was in Europe when all of this took place. This was during the Reagan administration, and he was quite appalled that one-third of his soldiers in Europe, and there were 500,000 soldiers in Europe at the time, over 500,000 of us. Of course, I wasn't a user, certainly, but I was doing some of the testing, as weird as that is. In 1980, 27.6% of the soldiers in the military tested positive for illicit drugs. By 1998, the level of illicit drug use in the military had dropped to 2.7%. By 2005, the level had been cut by more than 100% to 1.11%. And how did they do that? Most of these guys, they kicked out of the service. Intense drug testing can be credited for this success. The military has maintained a reputation for heavy drinking since its inception. A little story. I made sergeant when I was, how long? I'd been in for 3 years. And I made sergeant and then staff sergeant. Actually, I made staff sergeant before I made sergeant, which you can't do. But so when I made staff sergeant, this was in 1974, when I made staff sergeant, they told me I had to join the NCO club. And in order to support the NCO club, every time I went in, I had to buy 2 drinks. I didn't have to drink the drinks, but I had to, I didn't have to drink the drinks, but I had to buy them. And of course I refused. That was kind of silly. I was, I had 2 kids and no wife. So why in the world would I buy 2 drinks that I wasn't going to drink? That didn't make any sense. So I got in trouble. I got in trouble for not supporting the NCO club. They didn't bust me, but what they would do, they would have commander's call. They'd have commander's call at the NCO club. And of course, I couldn't go in because I wasn't a member. You had to be a member in order to go in, as weird as that is. Anyway, we all got through it. I got past it. And they changed all those rules. They had to change the rule for me because otherwise they would have had to have busted me. And the only reason they had was because I wouldn't support the NCO club. And that was kind of silly. In 1980, the level, okay, we already talked about all of that stuff, didn't we? No. It wasn't until after Vietnam and the drug control movement that the military began concentrating on curbing instead of promoting alcohol use. In 1980, the level of heavy drinking in the military was 20.8%. By 1998, the level had been cut by 15.4%. At present level, was actually increased to 17.1%, higher than the general public at 12%. While I was in Germany, well, we won't go into that. That's okay. The highest rate of alcohol abuse in the military is in the Marine Corps branch. The lowest level of alcohol abuse is in the Air Force, with the other 3 branches of the military, the Army, the Navy, and the Coast Guard, somewhere in the middle. And this is a Marine, and this is an Army guy, and this is a Navy guy. I'm guessing that's a Coast Guard. That's what the Air Force looks like. We're all ladies. No, actually, you can tell by the insignias. That's another Marine. It's a Marine insignia. Anyway, there you go. The Air Force was the first branch of the service to crack down on drug and alcohol abuse, and this makes a lot of sense. The other branches of the service have combat arms. Air Force doesn't have that much. It's got the SPs, the security police. They're about the only ones that wander around with weapons. But the Air Force has a lot of people that fix airplanes. And you really don't want your mechanic to be drunk. And for this reason, they were starting to have problems with airplane crashes. I was stationed at Lubbock, Texas. We didn't have an airplane crash for the first 3 years I was there. And then we had a whole spate of them. And lucky me, one of my jobs was securing the body from the crash site. That was one of my jobs. Anyway, we had a whole spate of them, and they did an investigation trying to figure out what was going on. Were the airplanes too? Was there a problem with the supplies? Were the airplanes too old? What was wrong with the mechanics? I mean, they changed the mechanics, and it really didn't do any good. What had happened was that they needed to crack down on the people using drugs. It was especially marijuana and alcohol, and that's you know out of that report, out of those kinds of reports. I mean, we were killing pilots. We were destroying $1 million aircraft. And so they decided that they needed to crack down on all that. So all that happened in the early 1980s. I left Lubbock in 1979. I was there from 63 through 79. The first military EAP was the Air Force's Alcohol and Drug Abuse Prevention and Treatment Program, the ADAPT. The Army soon followed with the Army Substance Abuse Program and the Navy's Navy Alcohol and Drug Abuse Prevention Program, the NADAP. ASAP, ADAPT, ASAP, and NADAP. And there you go. And of course, the Marines are in the Navy program. The military's programs have have been so successful because the military has almost absolute power over all military personnel. They can conduct urinalysis testing whenever or wherever they choose. If a military member refuses to comply to either drug testing or drug rehabilitation, the military can charge them with disobeying a direct order and can discharge them from the service. And that's exactly what happened. One of my jobs was collecting drug urines. Not the most fun job in the world. And the reason I got to do it was because I went into the service at age 22. I had just turned 22. So I was old enough to sign the legal form. If you were under the age of 21, you couldn't sign the legal form. So I got to do that. What a lucky ducky I was being able to do that. So I collected thousands and thousands of drug alcohol tests, or drug tests, actually, not just drug alcohol tests. With the influx of reservists and National Guard members into the active duty with the hostilities in Afghanistan and Iraq, the Department of Defense instituted the following drug policies: 100% random testing of all active duty personnel. That's when they first come in. Conduct random drug testing on all military personnel within 72 hours of entering active service. Separate positive testing personnel from the military, zero tolerance. Test the mandatory test panel to include new drugs, and that was kind of tough. Maintain 100% mandatory testing for DoD civilian personnel. There's a reason why drug testing has shown a 66% drop in positives from 1988 to 2004. Self-reported positives have increased by 30%. Drug users will avoid applying for jobs at businesses that require a drug test. There are ways to beat the drug test, though most of them depend on a non-observant specimen collector, which I was not. I was very observant. I didn't want anybody sneaking anything in on me. Reasons for drug testing include pre-employment testing, for-cause testing, random testing, post-accident testing, periodic testing, rehabilitation testing of criminals on probation, testing for compliance of addicts in treatment, testing by medical examiners to determine cause of death. 12 states allow for testing of welfare recipients. As I told you, one of my jobs was securing the body from an airplane crash. One of the first things we had to do was to collect specimens, drug specimens and alcohol specimens. So one of the things we had to do was to draw blood. Well, and when airplanes crash, usually there's a lot of fire, and that was kind of a problem. But we had to draw blood from them in order to test their blood for drugs. And we also had to test their urine for alcohol. Yeah. Oh, well, we could actually test their blood for alcohol too, but we had to test their urine for drugs. So we had to collect those specimens, and that's not easy from it's not easy from somebody who's dead. It's also almost impossible from somebody who has been in a fire. I won't tell you how we did it, but we always had to do it, and we had to secure those specimens before we did anything else. The most widespread testing is in the military, the federal government employees, pre-employment drug testing, in public safety positions, transportation, drug treatment facilities. Drug testing can be conducted on any substance from the body, urine, drug, hair, saliva, sweat, tissue if necessary, and of course, if there wasn't enough, if we it couldn't get a drug or urine. Actually, to tell you the truth, I collected a bunch of them, and I never failed to get a urine specimen and a blood specimen from the individual. Standard drug testing tests for amphetamines, cannabinoids, cocaine, opioids, phencyclidine, PCP, and alcohol. That's what is normally tested. Other drugs that can be added to the testing: barbiturates, benzodiazepines, methadone, propoxyphene, Darvon, and methaqualone. We tested for all of the. We couldn't test for cannabinoids. This was back in the 70s, but we did test for barbiturates and benzodiazepines. We tested for cocaine, opioids, amphetamines, and alcohol, barbiturates, and benzodiazepines. Drugs that are normally not tested for but can be added if suspected: LSD. It's such a tiny, tiny amount. LSD is really difficult to find. Fentanyl is a synthetic opioid. Psilocybin, the magic mushrooms, MDA, and the designer drugs. We can test for just about everything. Methods of testing include thin layer chromatography. This method tests for a wide variety of chemicals and is very sensitive to minute amounts of any chemical. The problem is that it can't differentiate between chemicals with similar structures, such as ephedrine and amphetamines. Enzyme multiplied immunoassay techniques emit radioimmunoassay, RIA, and enzyme immunoassay. Emit tests use antibodies to seek out specific drugs. It is very sensitive and rapid, but it cannot determine concentration and produces several false positives. Poppy seeds will test as heroin. Ibuprofen will test as marijuana. Vicks Vapor Inhaler tests as crank, as weird as that is. And we used to use radioimmunoassay in our tests. We actually had to send them down to Brooks Air Force Base in San Antonio, but we collected the specimens and got the results back. Methods of drug testing: gas chromatography, gas spectrometry combined, and gas liquid chromatography. This system is the most sensitive, accurate, and reliable method of drug testing, and we verified all our results as on a gas chromatograph. This system is most sensitive and accurate. This system is so accurate because the technique actually breaks each chemical into fragments and then reads the fragments. This method eliminates false positives and false negatives because it not only identifies the chemical structure of the drug, but it cross-references it with metabolites that it produces. This test is very expensive and requires highly trained operators. And when I was in lab school, 80% of the people in my lab class went to drug testing down in San Antonio. But I went into a laboratory to do lab work. Hair analysis can be done as most chemicals taken into the body are represented in the keratin of the hair follicle. Hair analysis tells the tester what drugs have been used while that specific hair follicle has been alive. Radioimmunoassay tests are run on the hair follicle. Confirmation is done with gas chromatography and mass spectrometry. If you've ever watched NCIS, they talk about mass spec. That's what they're talking about, mass spectrometry. And these are the techniques that we developed and we used in the Air Force. And we were some of the first ones to do it. Drugs can be detected on saliva, sweat, and on the breath. These tests are easier to obtain as they are less invasive, but they also only serve as screening tests and are prone to contamination. The alcohol breathalyzer is a good example of a breath test. Follow-up tests should always be done to confirm any results. There are many factors that influence the length of time a drug will remain detectable in a person's system. What is the drug, the absorption rate of the drug, the metabolism of the drug, the rate of distribution in the body, excretion rate, the method employed for testing. Detection range of psychoactive drugs. Alcohol, you can detect alcohol in your system for 3 to 5 days. Amphetamines, 2 to 4 days. Methamphetamines, 2 to 4 days. Barbiturates, short-acting barbiturates, only 24 hours. Clonazepam is 40 to 80 hours, and diazepam, which is a long-acting barbiturate, 7 to 30 days. Cocaine, crack, 6 to 8 hours. That's meth. Benzylcognaline, 2 to 3 days. Marijuana, single use, 1 to 3 days. 4 joints a week, 4 to 7 days. Daily use, 10 to 15 days. Chronic heavy use, 1 to 2 months. It stays in your fat. And nicotine, about 12 hours nicotine. Opioids, buprenorphine, 48 to 56 hours. Buprenorphine conjugates, 5 to 7 days. Codeine, 1 to 2 days. Heroin, 2 to 4 days. Hydromorphone, dilaudid, 2 to 4 days. Methadone, 2 to 3 days. Methadone maintenance, 7 to 9 days. Morphine, 2 to 4 days. Oxycodone, OxyContin, 2 to 4 days. Propoxyphene, 6 to 48 hours. PCP, if you're a casual user, 2 to 8 days. If you're a chronic user of PCP, it stays in your system for a really long time. LSD and its metabolites, 2 to 4 days. Ecstasy, 30 to 48 hours. Drug testing does seem to be reliably accurate, but it is not infallible. False positives can happen when dextromethorphan has been misidentified as opiates. Some herbal teas have been known to test cocaine positive. Poppy seeds from baked goods have been misidentified as opiates. Errors have also been found after testing personnel mishandled specimens. However, most laboratory errors are false negatives than any other error. Specimen can be manipulated by the testee to create a negative test when the testee is actually positive. Clean urine can be introduced into the specimen by concealed containers, urine injection into the bladder, and catheterization. That you're putting somebody else's urine into your bladder. That's what urine injection and catheterization are. Substances that have been introduced into the bladder to mask the drugs present with more questionable results include aspirin, golden seal tea, niacin, zinc sulfate, bleach, clear, water, ammonia, Drano, hydrogen peroxide, lemon juice, liquid soap, vinegar, and Visine. Of the people over 65, 83% take at least one prescription drug per day. I take 4 prescription drugs. 30% take 8 drugs or more a day. 17% of people over 60 in the United States abuse alcohol and illegal drugs. I don't abuse anything. Unfortunately, our society doesn't pursue elder drug abuse and alcoholism as fervently as they do these problems in younger individuals. Only 37% of elderly alcoholics are identified as compared to 60% of younger abusers. Drugs do not work in the same in the system of an elderly individual as they do with someone who is younger. Enzymes in the elderly tend to be less active than in younger people. This tends to make drugs more potent in older people. For example, the loss of liver enzymes means that an individual 70 years old will get the same effect from 10 milligrams of Valium as a 21-year-old taking a 30 milligram dosage. The most frequently abused drugs after alcohol for the elderly are Vicodin, narcotic cough syrup, Darvon and other opioid analgesics, prescription sedatives such as Klonopin, over-the-counter sedatives, over-the-counter sleep aids, Prozac, Zoloft, Buspar. While not everyone takes these medications in the prescribed manner, the elderly tend to have more problems than others. Could it be because of their memory? Overuse, taking more or many different types of drugs than prescribed. Underuse, failing to take appropriately prescribed drugs or the correct dosage. Erratic use, failure to take drugs in the right dosage at the right time. Contraindicated use, incorrect drug being used causing an adverse reaction or drug inactivity. Abuse and addiction, using drugs for non-medical purposes despite negative consequences. Common drugs abused by elders: nicotine, 94% of all 430,000 premature deaths from smoking are in people over 50. Tobacco's effects are actually more pronounced in the elderly because of their inability to clear toxins as they did when they were younger. Elderly smokers have twice the mortality risk of cardiovascular disease than non-smoking elders. Caffeine, the average consumption of caffeine for the elderly is 200 milligrams. That's 2 cups of brewed coffee. Caffeine toxicity can be seen at doses as low as 100 milligrams. When seniors use excessive caffeine, it can lead to loss of bone density, increasing the possibility of hip fractures. The most prevalent problem among elderly is alcohol. 6 to 11% of elderly hospital admittance show signs of alcoholism. ER visits find 14% of the elderly seen show signs of alcoholism. 20% of the elderly in psychiatric wards are alcoholic. 49% of the elderly in nursing homes are alcoholic. Because of the presenting medical problems, alcoholism is often overlooked by medical personnel. Alcohol affects the elderly so much more seriously than a younger individual because they have a less efficient liver, they have a decrease in body water, they have an increase in sensitivity to alcohol, they have a decrease in tolerance to alcohol, a decrease in metabolism of alcohol in the gastrointestinal tract. Lower amounts of alcohol will lead to intoxication for the elderly. Over-the-counter medications can cause the elderly problems. Sedatives contain antihistamines for their sedating effect, and the liquid forms have more alcohol than wine. Unisom, Sleep Ease, Nitol, and Sominex are examples of sedatives with antihistamines. Cold medications will contain the same combination of alcohol and antihistamines. Abuse of prescription drugs has been reported as low as 5% and as high as 33%. This occurs even in extended care facilities. Benzodiazepines are used by 71% of the elderly between 50 and 65, and 33% by those over 65. These drugs can cause confusion and falls. Abuse of prescription opioid analgesics has increased by 500% since 1990. OxyContin, hydrocodone, another name for hydrocodone, of course, is Vicodin, Lortab, or Norco. While few think of the elderly as drug abusers, of the total hospital admissions for the elderly, 20% are directly due to prescription or over-the-counter drug reactions exclusive of alcohol and illicit drug admissions. 20% of the elderly were regular drinkers and continue to exceed controllable amounts. 50 to 12% of men, 1 to 2% of 50 to 62% of men, and 1 to 2% of women. That must be 5 to 12% of men and 1 to 2% of women. 80% of senior arrests are for drunkenness. 5% to 12% of men and 1 to 2% of women. 80% of senior arrests are for drunkenness. Primary prevention for the elderly. The elderly need to be educated as to the changing effects of alcohol and the drugs as they get older and the increased dangers of excessive use. Secondary prevention with this age group involves recognizing the early stages of alcohol and drug addiction and appropriate intervention tactics. Tertiary prevention, treatment for the elderly, involves a slower pace of therapy focusing on patience and reassurance. And that is the end of that. So I'll talk to you guys in a couple of weeks. We'll tackle chapter 9. And then the last chapter deals with medications, not with illegal drugs. So I'll talk to you guys in a couple of weeks.